Welcome back to my channel. Learn with Professor Janula. If you're new here, don't forget to subscribe and hit the bell icon for notifications. In today's video, we're going to learn about placenta previa. Let's get started. Placenta previa happens when the placenta attaches itself in the lower part of the uterus, either close to or covering the opening of the cervix. First, this unusual position may not cause any symptoms, so the condition often stays silent. Second, as the pregnancy continues and the uterus stretches, this placement can lead to certain complications. Now we will see about how this change in position can become important later in pregnancy, especially because it affects the pathway for the baby during birth. Placenta previa is a condition where the placenta settles in the lower part of the uterus instead of the upper area. First, the placenta may be placed partly or completely over the opening of the cervix, which is called the internal os. Second, this low position can make the placenta lie very close to the birth passage or even cover it. Let's see about why this matters. In early pregnancy, it may not cause any signs, but as the uterus grows, this unusual location can lead to bleeding and other complications because the placenta blocks the normal pathway for the baby. Let's see about the different types of placenta previa. First, type 1 is called low-lying, where the placenta is in the lower segment but not touching the opening of the cervix. Second, type 2 is marginal, where the placenta reaches the edge of the cervical opening but does not cover it. Now we will see about the next kinds. Type 3 is partial, meaning the placenta covers part of the internal os. Type 4 is complete or central, where the placenta fully covers the cervical opening. This classification helps us understand how much of the birth passage is blocked and how it may affect delivery. Let's see about type 1, which is called low-lying placenta. In this type, the placental edge lies within 2 centimeters of the internal os, but it is not touching or covering the opening. First, the placenta stays close to the cervical opening, but it still leaves space for the baby's passage. Second, as the pregnancy grows, the placenta often moves upward because the uterus stretches. Now, we will see about why this is important. If the placenta shifts away from the opening, a normal vaginal delivery may be possible, making this type less risky compared to the other kinds. Let's see about type 2, which is called marginal placenta previa. In this type, the placental edge reaches the internal os, but it does not cover the opening. The placenta touches the edge of the cervix, yet it still leaves space for the baby's path. As pregnancy continues, the placenta may move upward, and if this happens, a normal vaginal delivery can become possible. Let's see about type 3, which is known as partial placenta previa. In this condition, the placenta covers a part of the internal os, so the cervix is not fully blocked, but still not safe for a normal vaginal delivery. Because the baby's pathway is partly covered, delivery through the birth canal can cause heavy bleeding. For this reason, a cesarean section is usually recommended for the safety of both mother and baby. Let's see about type 4, which is called complete placenta previa. In this condition, the placenta fully covers the internal cervical opening, leaving no space for the baby to pass through the birth canal. Because the placenta completely blocks the way, the baby cannot come out through the cervix. For this reason, a cesarean section is required to ensure a safe delivery for both mother and baby. Let's see about the risk factors for placenta previa. Women who had a previous cesarean section or a past history of placenta previa have a higher chance of developing it again. Multiparity and multiple pregnancy also increase the risk because the uterus has gone through repeated stretching. An advanced age mother is more likely to experience abnormal placental placement as well. Smoking can affect placental health and add to the risk. Uterine abnormalities, such as a bicornuate or septate uterus, can also make it harder for the placenta to attach in the right place. Let's see about the pathophysiology of placenta previa. In this condition, the embryo implants low in the uterus instead of attaching to the fundus. As pregnancy continues, the lower uterine segment stretches to make space for the growing baby, and this stretching causes the placental attachment to loosen. When this happens, painless bleeding occurs because the placenta gets disrupted. Cervical dilation during late pregnancy can increase the bleeding even more, as the opening widens and further disturbs the placental site. Let's see about the clinical features of placenta previa. The most common symptom is painless, bright red vaginal bleeding, usually appearing in the third trimester. The bleeding can come back again and again, and there is typically no abdominal pain. On examination, the uterus feels soft and non-tender. Because the placenta blocks the lower segment, the baby may not settle into the normal head-down position, leading to breech or transverse presentation. The fetal heart rate is often normal unless there is heavy bleeding that affects blood flow to the baby. Let's see about how placenta previa is diagnosed. Ultrasound is the main tool used, and transvaginal ultrasound is considered the gold standard because it gives the clearest picture. It helps identify exactly where the placenta is located in the uterus. This method is safe, accurate, and helps doctors confirm whether the placenta is low-lying, marginal, partial, or complete. Let's see about the important precautions and additional tests. A digital vaginal examination should never be done when placenta previa is suspected, because touching the cervix can disturb the placenta and cause severe bleeding. To support the diagnosis and monitor the mother's condition, blood tests such as hemoglobin and hematocrit are checked. A coagulation profile helps assess the blood's ability to clot. Fetal monitoring, including NST or BPP, is also done to check the baby's well-being throughout the pregnancy. Let's see about the maternal complications of placenta previa. One major problem is massive hemorrhage, because the placenta can easily bleed when the lower segment stretches. This blood loss can lead to hypovolemic shock if not treated quickly. There is also a higher chance of infection due to repeated bleeding at interventions. Because the placenta blocks the normal birth passage, the need for a cesarean section becomes much higher. Overall, these complications show why careful monitoring and timely treatment are important for the mother's safety. Let's see about the fetal complications of placenta previa. One major risk is preterm birth, because bleeding or maternal instability may force an early delivery. The baby may also present in abnormal positions, such as breech or transverse, since the placenta blocks the lower part of the uterus. Fetal distress can occur when bleeding affects oxygen supply. Babies born in this condition may have low birth weight due to early delivery or poor growth. In severe cases, especially when bleeding is heavy or untreated, there is a risk of perinatal mortality. Let's see about the initial management of placenta previa. If the mother has significant bleeding, she should be hospitalized right away for close observation. The healthcare team will stabilize her by checking airway, breathing, and circulation, and by inserting a large-bore IV cannula. Vitals and the fetal heart rate are monitored regularly to watch for any signs of distress. Blood is cross-matched, so it is ready if a transfusion becomes necessary. If the pregnancy is less than 34 weeks, corticosteroids are given to help the baby's lungs mature in case an early delivery is needed. Let's see about expectant management, which is used when the mother is stable, the bleeding is mild, and the baby is still preterm. The mother is advised to stay on bed rest or pelvic rest to reduce the chance of further bleeding. Intercourse and vaginal examinations are avoided because they can disturb the placenta. Maternal vitals and the baby's well-being are monitored regularly. If the mother has contractions, tocolytic medications may be given to help stop them. Repeat ultrasounds are done to check if the placenta moves upward as the pregnancy continues. Let's see about active management of placenta previa. This approach is needed when the bleeding is heavy or keeps coming back, or when the mother or baby becomes unstable. It is also indicated once the pregnancy reaches 37 weeks, because the baby is mature enough for delivery. Active management is especially required in cases of complete placenta previa, where the placenta fully blocks the birth canal. In these situations, planning for delivery, usually by cesarean section, is the safest option for both mother and baby. Let's see about the plan for delivery in placenta previa. Cesarean section is the recommended method for both complete and partial placenta previa because the placenta blocks the normal birth passage. In cases of marginal or low-lying placenta, a vaginal delivery may be attempted, but only if the bleeding is minimal and well controlled. This situation is rare, and most mothers with placenta previa will need a planned cesarean for a safe delivery. Let's see about intrapartum nursing care for placenta previa. The nurse prepares the mother for a possible emergency cesarean section because bleeding can worsen suddenly. The patient is kept NPO to ensure safety if anesthesia is needed. Continuous fetal monitoring is done to watch the baby's condition closely. The nurse maintains a patent IV line and gives oxygen if required. Strict intake and output are recorded, and emotional support and reassurance are provided. Throughout labor, the nurse carefully watches for any signs of shock, since bleeding can become severe very quickly. Let's see about postpartum nursing care for mothers with placenta previa. After delivery, the nurse closely monitors the mother for postpartum hemorrhage because bleeding can still occur. Fundal height and tone are checked to make sure the uterus is firm and contracting well. Uterotonics may be given to help the uterus stay firm and reduce bleeding. Vitals and the amount of bleeding are observed regularly. If the mother is stable, bonding with the baby is encouraged. The nurse also monitors for signs of anemia and gives iron supplements when needed to support recovery. Thanks for watching. I hope this session helped you understand placenta previa more clearly. If you found it useful, feel free to like, comment, share, and subscribe to support more learning content.